It's my pleasure to talk to you today about hypertension in children with chronic kidney disease. These are my disclosures, some grant support, and some royalties, nothing that is relevant for today's presentation. So here's a brief outline of what we're going to talk about today. Basically, the talk is divided into two parts. First, we'll talk about the role of hypertension and the progression of chronic kidney disease in children. In the second part, we'll talk about management, including which drug to use and what blood pressure to target. So there are many sources of data, many studies that have linked hypertension to the progression of chronic kidney disease in children. The three I'll talk about are listed here. One was a clinical trial of dietary protein restriction, then some registry studies, most notably Pediatrics, and then more recent data from the chronic kidney disease in children cohort study. So in this clinical trial conducted in the late 90s in Europe, 191 children with moderate chronic kidney disease, GFR, as you see here, were randomized either to a low protein diet or a standard diet with the intention of learning whether the low protein diet would result in less progression of CKD. And they were followed for 2 years. And these were the outcomes. So here in the left-hand panel, you can see that the low protein group in the dashed line had basically the same rate of progression as the standard protein group in the dark line. So it was a negative study in that respect. But then when you looked at two other aspects of the study, you do see more of an effect. So here for proteinuria in the middle panel, those who had less than 50 milligram per kilogram of protein today in the dotted line had slower rate of reaching the endpoint than those with a higher rate of protein excretion. And then pertinent to this talk, those whose systolic blood pressure was less than 120 in the dotted line were less likely to have progression than those who had higher blood pressure in the dark line. Now, with respect to the registry studies, there are two studies that have been done from the Pediatrics, which is the North American Pediatric Renal Trials and Cooperative Studies database. The first I'll talk about in more detail by Mark Mestefes in 2003, followed 3,800 children in the CKD registry and looked at systolic hypertension and whether it predicted more rapid loss of kidney function. And what they saw, again, after 2 months of longitudinal follow-up in the registry, children with hypertension reached the endpoint faster than those with normal blood pressure. And this was the difference, 58% versus 49%. And then when they looked at it by various levels of GFR, they saw that this was true at all levels. So that I'll show you here on the right. So here in the bottom panel are those with the highest level of GFR between 50 and 75 mLs, and those who are hypertensive in the dotted line reached the endpoint faster than those who were normotensive here in the solid line. Then for children whose GFR was between 25 and 49, the same effect was seen. And for those who had the lowest GFR, less than 25 mLs per minute, again, those with hypertension in the dotted line reached the endpoint faster than those with normal blood pressure. And then there was one other study by Amy Staples that was published a little bit later, again, followed a little over 4,100 children in the CKD registry, and they also showed that hypertension was an independent risk factor for progression. I don't have time to go through those data, you'll just have to believe me. Now, what about the CKD study. What have we seen in that group? So the first analysis, which was published about 5.5 years ago, looked at what factors led to rapid progression in CKD. And so about 500 children from the registry were followed. There were 400 with non-glomerular CKD and about 100 with glomerular CKD. And this was a little bit complicated, but they actually started following them after 1 year of being in the study because they wanted to look at what happened over that first year in a different part of the analysis I'm not going to discuss. But anyway, they wanted to look at what were the predictor variables for rapid progression. And this was defined as either initiation of renal replacement therapy or 50% reduction of estimated GFR. And so this is the main results table, and I'll just highlight the blood pressure data for you. So you'll see that in the non-glomerular group in this left-hand columns, those whose blood pressure was higher, denoted here as elevated compared to normal blood pressure, had a shorter time to progression. That's what this confidence in what this is showing here. This is a shorter interval to progression. In both the unadjusted and adjusted analyses, this was significant. And then those who had glomerular forms of CKD in the right-hand set of columns, again, had faster progression in both the unadjusted and adjusted analyses. And then sort of summarizing a little bit more from that study, it was shown that nephrotic range, proteinuria, and lower baseline GFR were predictors of progression to the composite endpoint for both glomerular and non-glomerular patients. That elevated blood pressure was associated with accelerated GFR decline, and that effect was greater in those with glomerular CKD than non-glomerular CKD. And I think that that's consistent with our clinical experience. They also showed in a different part of the paper that persistence of different biochemical abnormalities, such as acidosis, for example, contributed to progression. And actually, a study was recently published just looking at acidosis. So then we conducted a separate analysis of the children who had only non-glomerular CKD. And why do we do this? It's because that's the largest group of children, as you know, who we follow with CKD. These are all the children with different forms of CATCUT. And so we wanted to look at the relationships between baseline proteinuria, blood pressure, and longitudinal change in GFR. And we had 522 children with non-glomerular forms of CKD. We looked at urine protein creatinine ratio, standardized blood pressure, and iohexol GFR. Median follow-up was about 4 years, and many of these children had several GFR determinations. You can see here the list of diagnoses. This is just what you would expect: obstructive lesions, hypoplasia, dysplasia, reflux, and so forth. So what happened? Well, what was really interesting, and what I now tell parents, is that in the entire group, GFR declined by 1.3 mLs per year, which is pretty slow. When you looked at the effect of blood pressure, though, every 1 unit increase in blood pressure Z-score, so we had to standardize it by calculating Z-scores because, as you know, they're children of varying ages. So for every 1 unit increase in Z-score, there was a 0.4 ml per year faster decline in GFR. So that when you actually looked at the different blood pressure groups, those whose blood pressure was at the 50th percentile lost function only at 1.2 mLs per minute, but if the blood pressure was at the 90th, they lost function at 1.7 mLs per minute. And similar findings or trends were seen for diastolic blood pressure, but it wasn't as statistically significant. When we looked a little bit more closely, we were able to even pin it down more precisely so that those children with the lowest protein to creatinine ratio and normal blood pressure had the lowest rate of GFR decline, only 0.8 mLs per minute per year. But children who had either proteinuria or higher blood pressure, or interestingly, both together, had similar rates of GFR decline up to 1.9 mLs per minute per 1.73 meters squared per year. So I think this is really significant because we don't normally think of children with CACUT as having hypertension or having proteinuria, and we don't think of them as progressing rapidly. So this actually tells us differently that children, if do have proteinuria, they can have higher blood pressure, and that these things can result in rapid progression. We also looked at ambulatory blood pressure data and yet another study. So we looked at baseline ABPM, 322 patients. This is the categorization. So they were mostly either normotensive or hypertensive, a lot with masked hypertension, as you all know. And what we saw, and this is a little bit backwards, so bear with me, but for every 20% faster decline in GFR, you were more likely to have an abnormal ABPM. So putting that in the other direction, you had faster progression with an abnormal ABPM and more hypertensive, which sort of makes sense. So putting all of this part together, for the first half of the talk, we've seen that data from registry and prospective studies show that hypertension is a risk factor for CKD progression in children, and then the CKD studies show that this is true even in children with non-glomerular forms of CKD. Now, what about choice of agent? Well, if you look at different guidelines or textbooks, most will recommend use of an agent affecting the renin-angiotensin-aldosterone system for hypertension management in patients with CKD. Well, so why is that? Well, first of all, there are data in adults that show faster progression, or slower progression, sorry, with ACE/ARB treatment. I'll show you one guideline recommendation in a minute. And if you think about it, we know about the central role of the renin-angiotensin-aldosterone system in CKD progression. And we also have learned, again from the CKD study, that these agents actually control blood pressure more effectively. So this is a table out of the 2017 American Heart and ACC Adult Hypertension Guideline. And so what I want to draw your attention to is the recommendations here. So treat to a goal of less than 130/80 with hypertension and CKD. And in hypertension and CKD, high stage CKD or lower stage with albuminuria, use an ACE inhibitor to slow CKD progression. And then down here, if you don't tolerate an ACE inhibitor, well, you can use an ARB. And so what I want to actually point out also is this table. LOE stands for level of evidence. And so to make this second statement, they actually found that this second statement is supported by evidence from randomized clinical trials and from meta-analysis of randomized clinical trials. So very high level evidence supporting this recommendation in adults. Now, here's a nice cartoon for the mechanisms that lead to CKD progression, including things like glomerular sclerosis, scarring, fibrosis, and so forth. And right here in the middle is the renin-angiotensin-aldosterone system as the central player in the process of CKD progression. So obviously a logical target for treatment. Now, what have we learned from CKD? So this was a paper we published, wow, 12 years ago now, where we looked at the baseline blood pressure in the CKD cohort. In this panel, I want to call out this analysis, so there were 432 patients overall that we analyzed, but in this part, we looked at those with controlled versus uncontrolled blood pressure. And so let me blow this up for you a little bit. And so here you have our comparison of about 100 with controlled blood pressure and 100 with uncontrolled blood pressure. And down here are the drugs they were getting. And highlighted here, you can see that those who had controlled blood pressure in the right-hand column were more likely to be receiving an ACE or ARB than those with uncontrolled blood pressure here in the left-hand column. And then furthermore, we looked at what was the prevalence of uncontrolled blood pressure amongst those receiving different characteristics. And then drawing your attention to the bottom here, you can see that those who were receiving treatment with an ACE or an ARB had a reduced risk or reduced prevalence of uncontrolled blood pressure than compared to those receiving other classes of antihypertensive agents. Now, we also looked at this in the ABPM study, and in that study, about half of the participants were receiving ACE inhibitors. And if we looked at those who were receiving ACE inhibitors, they were way more likely to have a normal ABPM than those who did not report using an ACE inhibitor. And you can see here the odds ratios for normal versus abnormal ABPM in those receiving ACE inhibitors, and this was quite significant. Okay, so now what blood pressure level should be targeted? So I'm going to pull out the two pediatric guidelines. This is the American Academy of Pediatrics guideline published in 2017. And what you see here is that children and adolescents with CKD and hypertension should be treated to a 24-hour MAP below the 50th percentile by ABPM. That's in this middle part of the key action statement here. And then when you look at the European Society of Hypertension recommendation, so this is their CKD recommendation at the bottom, and they are saying, although they don't state it on the slide, that it should be by 24-hour ABPM. For those who don't have protein in the urine, should be targeted to below the 75th percentile of 24-hour MAP. And for those with proteinuric CKD, should target below the 50th percentile. So exactly what we wrote in the American guideline, although I think we said it a little bit more clearly. Now, where did this recommendation come from? Well, it comes from the ESCAPE study, as you all know. This was a prospective study of 385 children with chronic kidney disease conducted at 33 centers in Central Europe, mostly Germany and surrounding countries. All received a fixed dose of ramipril, and then they were randomized to either intensive blood pressure control or conventional blood pressure control based upon ABPM targets. Conventional was 24-hour MAP between the 50th and 95th percentiles. Intensified was 24-hour MAP below the 50th percentile. Endpoint was 50% decline in GFR for progression to end-stage renal disease, just as in some of the CKD analyses, and they had followed them for 5 years. So this is their outcome graph, which everybody has probably seen a million times, but you can see in the tan line, those who received intensified blood pressure control reached the endpoint less often than those in the conventional blood pressure control group here in the blue line. And then a graph you may not have seen because it's more complicated is this one, where they split out the glomerular patients from the dysplastic CKD patients. And so the top two lines are those with glomerular disease. You can see that those who had in the conventional blood pressure control group reached the endpoint a lot quicker than those in the intensified group. And they saw a similar difference in the CKD group way down here, where those in the conventional group in the blue reached it faster than those in the intensified group here in the tan. So that's the data for ABPM targets. But what about office blood pressure? You can't always do ABPM. So do we have any idea of what office blood pressure levels should be targeted? So CKD has hopefully answered that question with two papers that were just published in 2020. One looking at the entire cohort, and then one we looked at most recently just those who are hypertensive. Let me show you both of those studies in a little bit more detail. So in this analysis by Reynolds et al., published in early 2020, it looked at 844 children in CKD, so basically all of the patients in CKD, categorized them by different levels of office blood pressure, and looked at the association of CKD progression and blood pressure. They again defined progression as you see here. And what they saw, and I'll show you the graphs in a minute, that both higher baseline GFR was associated with faster progression, and that higher blood pressure over time also was associated with faster progression. And these are the main results slides. In the top half is systolic blood pressure, bottom half diastolic blood pressure, left-hand column non-glomerular patients, right-hand column glomerular patients. And you can see that in every single analysis that those whose blood pressure was greater than 90th percentile in the orange reached the endpoint faster than those with lower levels of blood pressure. So that's in the entire cohort. What about only looking at those kids in CKD who are hypertensive? So we just published this in November. We looked at achieved blood pressure levels over time and GFR outcomes. We narrowed the analysis to those who had a diagnosis of hypertension or whose blood pressure would have qualified them as being hypertensive. And we looked at that over time, and we saw that if blood pressure was maintained below the 90th percentile, that was associated with a decreased risk of progression for those with glomerular CKD. We looked at non-glomerular CKD. We saw the same thing, but we also had a little bit of a signal that office blood pressure between the 50th and 75th percentiles might be even better in those with non-glomerular CKD. And here are our results graphs. So these are a little harder to read, unfortunately, but on the left-hand side are the glomerular patients, right-hand side of the non-glomerular patients. The gray line are those whose blood pressure stayed above the 90th percentile. And so you can see in the glomerular group, those people progressed really fast. These other colors are all the other blood pressure groups, and in the glomerular patients, they all were sort of lumped together. This is the non-glomerular patients. Again, those who had blood pressure above the 90th progressed the fastest, and the slowest seemed to be those between the 50th and 75th percentiles here in the orange lines. So very interesting. Okay, so summarizing this part of the talk, we've seen that agents blocking the RAS provide superior blood pressure control in patients with chronic kidney disease, and they're recommended in all the adult guidelines, and that we have evidence that maintaining 24-hour MAP below the 50th percentile by ABPM results in slower progression. And we have evidence from CKD that if you can keep the office blood pressure at least below the 90th percentile, that's also associated with slower progression. So putting it all together, what we've talked about today is that there's ample evidence that hypertension, particularly uncontrolled hypertension, leads to faster progression of CKD in children. And we've seen that if you can reduce the blood pressure, office blood pressure below the 90th percentile, or 24-hour MAP below the 50th percentile, and you treat with an ACE or an ARB-based regimen, that can also be helpful in slowing the progression of CKD. And I thank you for your attention, and I look forward to answering your questions.